Hi, Dr. Yoshida. How are you?
Not bad. So I guess you're Janice?
Yes, I'm Janice. I'm a family medicine resident in Florida, USA.
Okay.
And nice to meet you. I'm honored to be doing
Likewise.
I'm honored to be doing your interview. I'm representing Indo-Canadian Voice newspaper. So on behalf of them, I'm doing the interview. If you don't mind getting us started with a little background about yourself, if you can, let us know a little bit.
Sure. I'm a liver specialist, gastroenterologist, professor of medicine at the University of British Columbia. I've been involved in liver research for many years.
Okay.
I've worked with national societies. I was the president of the Canadian Association of Study Liver, and I've been the chair of the Canadian Medical Advisory Committee of the Canadian Liver Foundation for about 14 years.
Okay.
Need to know anything else?
Yeah, I would like to know how you became involved, with the liver health and these associations that you're affiliated with. Was there something that drew you towards
Well,
it?
no, I've been involved in. I mean, I've been on staff at the Vancouver General Hospital and the University of British Columbia for close to 30 years,
Okay.
and so there, at the beginning, there really wasn't much going on, and there was a great need.
Mm.
So I kind of just, like, I started as a gastroenterologist, and I was involved with the liver transplant program.
Okay.
Still involved with the liver transplant program. And when you're dealing with the liver transplant program, there's a tragic discrepancy between the number of people who need life-saving livers, and the number of organs that are actually available.
Right.
Um, back then it was like 4 to 1.
Okay.
And back in those days, there was about a 30% of the people who were enlisted for liver transplantation, about 30% would die of their liver disease without any organ ever becoming available. So it was pretty nasty. It was pretty traumatic.
Okay.
I mean, back then it's like there weren't any effective treatments for hepatitis B and hepatitis C and um, that
Yes.
kind of thing. So,
Yes.
uh, and we excluded like a lot of, I mean, there was a 6-month rule for alcohol back then, which we don't have anymore, which excluded a lot of patients.
Sure.
There was a lot of barriers that over the years as research has shown really were not realistic barriers. And so, um, it's like there's more and more conditions that are transplantable, but we also have more organs. In British Columbia, back in the 90s, we had maybe 35 to 36 organs per year. And now like last year, we transplanted 117. We, we,
Wow.
I mean, we don't have a live donor liver transplant program yet, but we will. So the number of available organs should even be higher. So, from that background, it wasn't difficult to get into the other aspects of liver disease. I mean, the hepatitis C was a total disaster. There weren't any effective treatments, and then through research, effective treatments became available, and now I think hepatitis C is actually on its way out. But
Yes.
there's still a lot of other things that need to be done. I mean, fatty liver disease is increasing. Non-alcoholic fatty liver disease, also called metabolic associated steatotic liver disease, although I'm not sure MASLD is going to catch on
Yeah.
because it includes alcohol, but and a lot of patients, they actually want to hear that it's non-alcoholic. So
Right.
it's important for them to have that non-alcoholic steatohepatitis or non-alcoholic fatty liver disease in the title of their illness. And that in BC, it's about 25, maybe 30% of the population. I suspect in Florida, it's probably a 40.
Okay.
So, I mean, liver disease just keeps going on.
Uh-huh. That's right. So you've talked a little bit to us about the different types of fatty liver disease. Could you tell us, so you mentioned non-alcoholic fatty, so fat, not necessarily attributed to alcohol. Are there other causes that, the public should be aware of, that can lead to NASH or non-alcoholics, all the various names of non-alcoholic fatty liver disease?
Well, I mean, to be honest with you, alcohol, at least in Canada, is a huge problem, and I suspect it's even more so in the United States. That causes like all kinds of liver disease, and even people who drink heavily and don't have cirrhosis, they sure as hell have a lot of fatty liver.
Yes.
But taking away that side, there really aren't that many conditions that will cause fatty liver disease outside of metabolic syndrome. I mean, hepatitis C can, but that's on the way out. Wilson's disease can, but you're talking about a disease that affects maybe 1 in 30,000 people, and it's quite rare. So basically, it's metabolic syndrome. It's obesity. It's
blood pressure.
Having blood pressure. That's part of metabolic syndrome, but in particular, weight gain, having a sedentary lifestyle, eating a lot of carbohydrates, eating a lot of fatty foods, drinking a lot of soda pop. Those are the things that lead to fatty liver disease.
Okay.
And I mean, it's a well-known trap. And back in the 1930s, during the Depression and when people were starving to death, I suspect there was no fatty liver disease, and yet it's dominant in Canada, the United States.
Right.
It is basically it's disease. I think it's a disease of, I shouldn't say an affluent society, because people who can't afford healthy meals eat a high carbohydrate processed food diet. But certainly it's a factor of living in a modern society where calories are readily available, and basically everybody is sedentary, because the people used to work on when America and Canada were rural communities, and there was a lot of hard labor on farms and in factories. People got enough exercise at work, but now that's not the case. I mean, you and I are on a computer, right? There's people who they spent their entire working day on a computer looking at a screen.
Correct.
And in between, they have snack breaks, they have lunch, then they go for dinner, and then what do? They probably play video games, or browse the internet, or they watch television.
TV, yeah. Exactly. So who would you say is at risk for fatty liver disease in a representative population?
Well, I mean, to be honest with you, everybody. But if you look at the United States of America, where race is always studied, there have been studies that suggest that African Americans have a little bit less fatty liver disease than non-Hispanic Caucasians, and Hispanic Caucasians have a lot more. And I mean, that's what we see here too. It's like our own research in Vancouver suggests that the Filipino community, which is Asian, but there's also a strong Spanish influence, has a lot of fatty liver disease. And some of that is dietary and cultural, but you really wonder if there's some genetic factors. The Indo-Canadian community of Vancouver and British Columbia has a lot of non-alcoholic fatty liver disease. And the United States, that's such a small community that they're not even studied, right?
Right.
They're lumped together with the East Asian. So in the United States, Asian means like Chinese, Japanese, or from India. Whereas in Canada, it's more East Asians and South Asians, so they're not lumped together.
Right.
But even in East Asians, like there's this phenomenon of skinny non-alcoholic fatty liver disease, which
that's right.
They've studied Japanese Americans and found that they had a lot. And I have no doubt that Chinese Americans and Korean Americans and Korean Canadians and Chinese Canadians also have a lot. And it's probably, you know, to be honest with you, it's probably the carbohydrates, the white rice, the white noodles.
Yes. Can you,
So,
for the average listener who may not understand the, like the skinny fatty liver disease, can you put it in simple words what that would look like so people are aware that you can have fatty liver disease without, being fat or being overtly overweight?
well, it's people who don't look like they're obese. They're not going to get fat shamed by anybody, but yet their livers really are packed with fat.
Mm-hmm.
I mean, it
Yeah.
could be you or I, or
Yes.
anybody else on walking down the street or on the subway or anything.
Right. So there's no way to tell from appearances if someone may or may not be suffering from fatty liver disease, is what I'm gathering from your words.
I mean, you're right, but I mean, you could guess that the person who is an obsessive runner and eats extremely healthy and looks, if anything, too skinny, yeah, they probably don't have fatty liver disease, right?
Got it. Okay.
But generally, yeah, it's hard. It's hard to tell.
Okay. So can you tell us why it might be important to get tested for this?
Well, one is fatty liver disease, whether it's, I mean, non-alcoholic fatty liver disease, can progress to increasing fibrosis, which may end up as cirrhosis. And there is some evidence that maybe it's an independent risk factor for liver cancer. But
Okay.
the fact of the matter is that, the biggest killer of people with non-alcoholic fatty liver disease actually isn't cirrhosis, and it isn't liver cancer. It's actually heart attacks and strokes, followed by an increased overall risk of any kind of cancer.
Okay. Interesting. Does it increase inflammation in the body in general?
Um, well, I guess some smart scientists might know the answer and publish it, but the thing is, I don't personally know, but I mean, there's lots of evidence that obesity itself increases the risk of, and inactivity increases the risk of cancer compared to those who are not obese and are physically active.
Okay. Got it. Got it. So would you say it's a good idea to get tested for fatty liver disease in the general population?
I think so.
All right. So, Dr. Yoshida, if you can talk to us a little bit about how did the Liver Beware FibroScan screening project come about?
Well, basically it came about because in Canada, especially in Vancouver, it's difficult to get a FibroScan and a controlled attenuation parameter study, which is the indicator of fatty liver disease, like
Okay.
CAP study. So it's actually very difficult. It's not available except in a few locations in Vancouver, and outside of Vancouver, it's probably not available elsewhere, largely because in Canada, where we have socialized medicine and patients don't pay for the testing or they don't pay for physician and surgical consultations and procedures. It's, there's no private pay, right? And if the government doesn't provide a fee code for a specific test, that means that nobody's going to get paid for doing the test. And so that's why there's less availability. And so I think it was just the brainchild of one of my colleagues that this was a great need. And there were some donors who shared that vision and were willing to come up with a program that the Liver Beware program would be include FibroScans. I mean, before the Liver Beware program was about hepatitis B testing, largely in the East Asian community, because I mean, there wasn't that much testing going on back then. So it kind of just stemmed from there, a great public health need.
Okay. All right. So what does the FibroScan test for in specific? Can it detect fatty liver disease?
Well, the FibroScan machine, the unit consists of two components. There's transient elastography, which uses sound waves to generate a profile that has been compared to a gold standard of people who had liver biopsies, and then you could tell there. I mean, there's a correlation with fibrosis scores, like F1, F0 to F1, which is minimal to mild, F2, which is getting up there, F3 means you're close to cirrhosis, F4 means you actually have cirrhosis.
Okay.
So there's that component. And then there's the controlled attenuation parameter, which is another similar technique where they can determine from the readings what the fat content of the liver is.
Okay. So if go ahead.
Yeah, so I mean it's non-invasive. It's done in minutes. It's just that in Canada there's very little availability.
Got it.
I'll bet in the United States they're doing a lot of it. I have no idea, but I suspect they're probably charging people, and then people are going to clinics and getting their insurance to reimburse them for this test. I mean, that's why it's happening.
Yeah, here with with privatization and different like personalized health insurances that the patient population here has, it depends first of all what their insurance is to see if they would get a good enough coverage, and then on the physician side for us to make sure the patient is covered, like you were mentioning, it's about coding. So if we put in the right disease diagnosis, and unfortunately in the US, there is a very high incidence rate of morbid obesity, high blood pressure, like you mentioned, the metabolic syndrome, all the components of it. So a lot of our population does, I would say they do fall into the criteria for getting scanned for this. But I personally, I've not heard of specifically a FibroScan. It sounds very detailed and in depth. You mentioned two components, maybe one generating a fibrosis score and another generating like a fatty component of the liver. That is a lot more detail. Like we may order a CT scan to assess for it, which obviously I'm sure you're aware is a very non-specific test. So I think it's great that you guys are offering a very detailed analysis for people to benefit from, to get more knowledge about their livers. So so to answer your question, I'm not sure if it's ordered a lot. I think the awareness is not quite there. Maybe if I speak to gastroenterologists, they would be able to speak better on the matter. But yes, so just to go further into the testing, I know there's there's some different numbers on the test, the results, right? Can you tell us what do they mean? Like there's a CAP score, CAP, or I think you
that's
talked
the CAP
about it.
score. That's the CAP score, and then there's the transient elastography score. And for the transient elastography score, which measures fibrosis, it's dependent on what liver process you have. So for fatty liver disease, the scores are different, say for hepatitis B or hepatitis C.
Okay.
I'm not really sure why that is, but nonetheless it is.
Okay. All right. So now that let's say I get this test done and I know I have fatty liver disease, can you tell us what are my options and what I can do about it?
Well, first is lifestyle changes, right?
Okay.
Low carbohydrate diet, more physical activity, maybe see a dietitian.
Okay.
And then there's pharmacologic therapy. Ozempic is becoming incredibly popular.
Yes.
There's a new drug that the FDA licensed, produced by a company called Madrigal, called Respirom. I can't pronounce it. Respirom. But it's like I don't know what the pricing is. I mean, the studies sound very good, but in Canada, it's like we suspect the pricing is going to be so out out of sight that the government drug policy plan called Pharmacare isn't going to cover it. I mean, in
Got it.
Canada, we have, I mean, in the United States, a lot of people have private insurance. In Canada, people tend not to have private insurance. And so the government provides a drug reimbursement plan called Pharmacare, which, it works well. I mean, it provides a lot of Canadians drug coverage that they would not have had otherwise, but they restrict what's on their formulary, and it has to be cost effective for them.
Okay. Would you say that, people who find out that they have something along the lines, something on the spectrum of fatty liver disease, do you think they have good enough options regardless in terms of lifestyle modification and medication? Do you think there's room for improvement, potentially reversal of fatty liver disease?
Well, I mean, yeah, I mean, potentially, there are lots of people who, through dedicated exercise and dieting, have reversed largely the fatty liver disease. I've seen some dramatic reversals with Ozempic. Bariatric surgery is another thing that probably I haven't mentioned because I'm a gastroenterologist, but there are some who, even metabolic specialists, who advocate bariatric surgery for their patients, and the studies seem to indicate that, yeah, it works pretty good.
Yes. Yes. Okay. All right. So if the reversible risk factors are able to be attended to, you're saying that fatty liver disease has a lot of scope to be reversed, or at least to mitigate the side effects of it. Yes.
Well, yes. I mean, to be honest with you, why is it that generations ago, there was no fatty liver disease?
Yes.
And why is it that fatty liver disease is common in affluent societies, and yet in countries that there aren't many calories, and it's not mechanized, and there's still a lot of hard physical labor jobs, there is probably less fatty liver disease.
True. Do you think if people worked on caloric restriction, that would contribute to reducing the incidence of fatty liver disease?
For sure.
Okay.
For sure. But then it's like, then you have to look at, well, why do they consume a lot of food?
Right.
Especially high calorie food. Well, one is, I mean, I'm not an expert in this, but one is the food probably tastes good, and we're programmed to like things that taste good.
Yes.
Two, it's social. Everybody is eating. Three, there's some emotional attachment to food. When people are under a lot of stress, they tend to fall back on comfort food, or they fall back on alcohol and other substances, which would be bad. So there's a lot of reasons why people consume a lot of calories.
Right.
And
so it's
you can't really fat shame everybody, because I'm sure there's a lot of people who, like, they're not in their situation because they neglected their health or things like that. It's just the way it is.
Right. And is there a genetic predisposition as well?
Oh, there is. There's a polymorphism called PNPLA, I think LA25 or 35. But they've isolated this SNP, the single nucleotide polymorphism, as having an increased risk of fatty liver disease. And once you know it, the Hispanic population seems to be, from an epidemiological view, seems to have more of this polymorphism than other people.
Okay. All right. So maybe there is this genetic component, and maybe
for sure,
who have familial hypercholesterolism, these all probably contribute to it.
Well, let me just quickly look up that PNPLA stuff.
Absolutely.
I mean, from a clinical point of view, it doesn't make that much difference, but PNPLA3.
LA3. That's the allele, the genetic gene.
Yeah, well, it's a polymorphism. I mean, it's not necessarily allele, but it's a polymorphism that's in the population that seems to for reasons, I mean, it must code for something with metabolics, but the populations that tend to have more of that polymorphism, there tends to be more fatty liver disease. And I think that's basically the Hispanic American population that they've identified.
Understood, understood. So, Dr. Yoshida, so I gather, from what we've talked about so far, essentially everyone is at risk, can be at risk for, fatty liver disease, and especially the Asian population, regardless of skinny, obviously more in the higher BMI population, but
Yes.
also, the visceral fat population. And it seems like it would be a good idea to get this scan, especially, through this research project, you guys are providing it to the population. So, it seems like a very, a very generous, uh-huh.
I mean, I really wouldn't. I don't regard it as being a research project. Yeah, they are collecting data so they can publish it, and why wouldn't you? Because it's never been done before. But it's more like a public health initiative.
Okay.
As opposed to a research thing. I mean, so I think it's more like a public health initiative on a small scale.
All right. Yes, and I agree. I think it is definitely something to help usher the at-risk population to be able to get more insight into their bodies and be more familiar and just equipped with the knowledge to head backwards in terms of like having healthier genetics and improving their lifestyle to kind of go towards a more healthier body. Do you have any advice or kind of closing words that you would like to speak to in terms of fatty liver or gut health or things in this matter in general?
Well, I think, live a healthy lifestyle and avoid alcohol.
Okay. All right. Yes, very good. I think both very easily said and very rarely seen in the population.
Yeah.
So,
So let me ask you a question.
uh-huh.
So this is a newspaper interview or is it like a radio interview?
This is a newspaper interview, but we have online updates, online
Okay.
information as well. So it will also be a video interview as well as a written interview.
Okay. And your publication is the
Canadian Voice.
Canadian
Yeah,
Voices, but you're in Florida.
that's right. Yes, I'm affiliated
So-
with the newspaper, so I'm doing this interview on their behalf. However, it will be published in Canada, and I am
Okay.
Canadian.
Oh, okay.
Yeah,
So
so
life
it will
is
be
better in
published on the
Florida, right?
website. Sorry?
Okay. That's the life is better in Canada, in the United States, right? So are you going to come back to Canada?
I've been asked this a lot. I really don't know. I think my career is at fork. I could either stay after residency or go back, but I haven't made up my mind fully yet. There's a lot of factors that will play into it. I would love to come back to Canada. I have nothing against it. I love free healthcare. But I'm not sure yet, is the short
Okay,
answer.
sounds good.
Yeah, but it's good. So thank you so much, Dr. Yoshida. I
No
really
problem.
appreciate your time and your expertise. You're a specialist, a well-versed, for many years in this field. And so your time and your knowledge, we really appreciate you, sharing that, and especially this health initiative. I think a lot of people have a lot to gain, a lot of insight, and then just awareness, and be able to, on a grand scale, hopefully be able to start marching towards better health. So
Good. Thank you.